Welcome back to the Thinking Mind podcast. My name's Alex. I'm a consultant psychiatrist. Today we're in conversation with Professor Henry O'Connell. Professor O'Connell is a consultant psychiatrist working in Ireland and an associate professor with the School of Medicine at the University of Limerick. He has a special interest in how principles of evolutionary psychology can be applied to psychiatry, mental health and illness, and medical education. He's written a range of articles on this topic. He was also the founding chair of the College of Psychiatrists of Ireland Evolutionary Psychiatry Special Interest Group. In 2022, he published the textbook Evolution and Psychiatry Clinical Cases. Today we discuss what does it mean to take an evolutionary approach in psychiatry, the difference between proximate and ultimate causes of mental illness, the idea that natural selection doesn't care about your happiness and what that might mean about your quest for happiness, the idea of evolutionary mismatch, as well as evolutionary perspectives on psychosis, anxiety, panic attacks, ADHD, and bipolar disorder. This is the Thinking Mind podcast, a podcast all about psychiatry, psychology, psychotherapy, and related topics. If you like it, there's a couple of ways you can support it. You can share it with a friend, follow or subscribe on Apple, Spotify, YouTube, wherever you listen. Give us a rating, or if you want to support us further, you can check out the Buy Me a Coffee link in the description. Thanks for listening, and now here's today's conversation with Professor Henry O'Connell. Thank you so much for joining me today.
Thank you, Alex.
Today we're going to talk about evolutionary theory and how we can apply it to psychiatry, both clinically when we're interacting with our patients, but even theoretically in terms of how we might think about mental health, mental illness, people suffering. It's not actually common, despite the fact that on podcasts and things like that, there's a lot of interest in it. It's not actually common for psychiatrists to think about evolutionary theory when they're practicing. How did that happen for you? How did you find your way into this niche?
Well, it was by accident, really, Alex. In the late 90s, when I was a junior trainee in psychiatry in Ireland, I had a chance discussion with a colleague of mine, Dr. Tom McMonigal, one evening, and he told me about this whole area of evolutionary psychiatry and gave me some textbooks, and he told me that he had no doubt that this perspective would change my whole view of psychiatry, and he was right, of course. And since then, well, over the subsequent years, I was fascinated in the area, but it was very much a background hobby for me, because, as you know, as a trainee psychiatrist, it's busy in terms of clinical work and getting through your examinations and being involved with research and audit and so on. So it was more of a background hobby that I kept maintained, but never really had the chance to fully immerse myself in. But I did write a couple of letters and a few brief articles which I had published in the area. And then in 2019, for Darwin Day, February 12th, I gave a talk in the area where I was working at the time to a group of trainees on evolution and psychiatry. And I was pleasantly surprised to find that there were a number of people who were enthusiastic about the topic. And specifically, there was Dr. Mara Petrut and Dr. Diarmaid Boyle who joined me, and we started to present on the whole area of evolution and psychiatry over the subsequent year or two at College of Psychiatrists of Ireland meetings and University of Limerick meetings. So with that, we developed some momentum, found that there were interested colleagues out there. Then I applied to the Irish College, the College of Psychiatrists of Ireland, in late 2020, early 2021, to start a special interest group, and they very kindly accepted our application. We were able to make contact virtually with our UK colleagues, Riyad Abed and Paul St. John Smith, with Randolph Messi in the US, and many more as well. So as a result, we were able to arrange a number of academic meetings, lectures, which we recorded and uploaded on YouTube. We've had a lot of views and followers from that. So over the last year and a half, we've published several articles, mainly descriptive articles and reviews on different topics in relation to evolution and psychiatry and evolution and mental health generally. Gurjot has actually applied, he's registered for an MD on evolution and psychiatry as well, which is a very exciting development. It's probably the first MD on evolutionary psychiatry that we know of in the world, and that will generate new research and new writing in itself. So I think as well, now that I've settled into my consultant life, I have a little bit more time in terms of immersing myself in this academic area. And I think it's very important as a consultant psychiatrist, when you're busy clinically every day, to have some outside academic interest. And I certainly find the evolutionary perspective is very broad and very energizing for me. And I hope that rubs off on my colleagues and on my patients as well.
What's the gap in psychiatry, do you think, that an understanding of evolutionary theory helps us to fill?
I suppose it's an endless, there are endless applications at the clinical level in terms of helping people we see on a daily basis in clinical practice. I think the evolutionary perspective can inform medical education, it can inform clinical research, it can inform how we interpret genetic research as well. So it's endless really. Once you start looking, you start to realize that, well, I have anyway, and interested colleagues realize that unless you have an evolutionary perspective, your view of clinical psychiatry and psychology and humanity in general is limited unless you take into account the evolutionary perspective. So, just jotting down a few key points before we spoke, I was thinking about some key principles that really are so important to come back to in any of these discussions. And the first one is a very obvious one, which is that evolution is a basic bedrock science of biology. And if medicine and psychiatry are biological sciences, then how can we study medicine and psychiatry without taking into account the whole concept of evolution? So that's one first principle. Another principle that's very important, I think, to bear in mind in any discussion is that the evolutionary perspective takes us beyond the proximate approach to mental and physical illness. So instead of asking what's going wrong in a particular clinical scenario, the evolutionary perspective broadens that and helps us to think in terms of the systems that underlie what may be going wrong. So instead of asking just what questions and taking a mechanic approach, the evolutionary perspective asks how questions and what systems behind the illness are at play. So it takes more of an engineering approach that complements the standard approaches that we'd currently take. That's another point worth emphasizing, that I don't see the evolutionary perspective as being in any way alternative or replacing existing models, but it should add a new layer of meaning to what we do. So there are two key principles. First of all, that evolution is core to biology, and that evolution asks ultimate as well as proximate questions about mental health and mental illness. Then there are three further key principles that are worth emphasizing. Firstly, biological evolution is a slow process. It's directionless, it's blind, and there's no ultimate outcome. Whereas societal, cultural, technological evolution and development occurs at a much more rapid rate. So as a result, for us as a species, we've spent 95% of our time in particular pre-industrial, pre-agricultural settings, and our bodies and our minds have evolved and developed and adapted to those settings. But the changes that have occurred for humanity in the last 10,000 years with the advent of agriculture, and subsequently with technological developments, and in more recent centuries, the Industrial Revolution and the IT revolution and AI, means that our current modern environments are unrecognizable from the environments in which we as a species evolved. So this leads to multiple areas of mismatch between our so-called environments of evolutionary adaptedness, the environments that we evolved to manage in, and our modern environments, which are, as I say, unrecognizable in comparison. So that's one key principle, that biological evolution is slow in comparison to our technological, cultural, social evolution. There's another aspect to that, which is that our own biological evolution is slow in comparison to microorganisms as well. So that means we can be at a disadvantage, and there can be a kind of an evolutionary arms race with microorganisms, for example, as seen during the COVID pandemic, where we were constantly battling with new strains as they emerged from the different virus strains. The next principle is that evolution is imperfect, so it's a blind, directionless, imperfect process, and it leaves lots of glitches. So we have, physical glitches like our wisdom teeth and appendices and back pain and so on. So likewise, we have lots of emotional and psychological glitches as well. We're not, even though we might like to think so, we're not the finished article. We're not perfection by any means. So that's very important to bear in mind. And then another point to emphasize is that evolution, unfortunately, is not interested in our health or our happiness. So, for example, while having a high temperature or being nauseated or vomiting is unpleasant, it may actually be good for us. It may help us to get through illness and may help our survival and reproductive chances. So likewise, certain levels of psychological distress, such as certain levels of anxiety or low mood, can actually be helpful to a point. And just because we're miserable doesn't necessarily mean that we're not going to survive and reproduce. And evolution is only really interested in seeing what happens in terms of our reproduction potential. So that's another key point worth emphasizing. There is a caveat to that just because a certain level of anxiety or low mood is not necessarily pathological or it should not be classified as being a disorder. Likewise, we should not view severe mental illness as being adaptive either. So the types of conditions we see in clinical practice, such as schizophrenia and bipolar, are very, very serious and debilitating conditions, and they don't really confer any advantages in terms of survival or reproductive fitness. But the evolutionary perspective shines light on the fact that the underlying systems that go awry may, if better modulated, may confer benefits or advantages. So there are some key principles to bear in mind. As I say, evolution is core to biology. Evolution takes us beyond just how questions to why questions. Evolution is slow, it's imperfect, and it doesn't really care about our health or happiness as long as we're surviving and reproducing.
Excellent. So there's a lot of different directions we can go in. I think you're very right that evolutionary theory isn't supposed to replace any aspect really of our understanding of mental illness, but rather it just gives us some more context. And it reminds me a bit of the distinction between Freud's idea of the personal unconscious and Jung's idea of the collective unconscious, which coincidentally I talked about recently on another podcast we did all about Jung, where we talked about that distinction. It's like Jung, I don't think, was dismissing the idea of a personal unconscious, but rather he was adding a deeper level, the collective unconscious, that perhaps there's not just an unconscious to every individual, but kind of a common unconscious of our species. And similarly, evolutionary theory just gives us a bit more context. Now, just now you've outlined 3 huge principles, each of which separately changed my clinical practice. So the distinction between proximate and ultimate causes, the idea of evolutionary mismatch, and the idea that evolution fundamentally doesn't care about our happiness. Let's take those one by one. Can you give me an example of proximate and ultimate causes as it can apply to either mental or even physical illness? Because I think it can actually apply to both.
Yes, exactly. I think it's interesting you mentioned Jung as well, because one of the first, if not the first book I read in the area was published in the mid to late 90s, Evolutionary Psychiatry, and it was written by John Price and Anthony Stevens, and Stevens was a Jungian analyst, and he merged a lot of evolutionary principles with evolutionary principles with Jungian principles as well. Now, some of it was I suppose speculative, but it was interesting as well. That he kind of drew some comparisons. But in terms of proximate and ultimate, so if we were to take maybe a relatively concrete example like mood disorders, say for example we take take bipolar affective disorder or recurrent depressive disorder, the proximate approach to conceptualizing these conditions is that you have a certain number of symptoms, and once you go above a certain number of symptoms, you fulfill criteria for caseness, and you have a depressive episode or a manic episode, and then you require treatment with medication, and the medication is focused at some, I suppose, end point in terms of a process. So the medication may help to stabilize neurons or increase serotonin at the synaptic cleft or whatever it might be, whatever the theory might be. And all of these theories are, I suppose, they're still quite fluid in psychiatry. But the proximate approach is that you're trying to fix some endpoint issue with medication. Whereas the ultimate evolutionary approach to take, which I think is much more satisfying for clinicians and for patients and for families, is that we all have underlying mood systems. Randolph Nessy refers to these as our internal moodostat systems, and we wouldn't be human if we didn't have normal variations in our mood. So if we're confronted with a loss or a stressful or difficult situation, we all have a propensity to become mildly depressed. And that state can confer some advantages in that we may become more reflective, and our appraisals of situations may be more objective, our problem solving may be better. But if that normal downward variation in mood becomes extreme, then we may become clinically depressed to a point where we are neglecting ourselves, we become suicidal, we're not able to function. So likewise with upswings in mood, we've all been there in terms of, having a euphoric upsurge in the context of some opportunity or some positive change in our lives, where we may be able to go without sleep for a few days and maybe able to focus on a task or an opportunity. And if that upswing in mood overshoots the runway, as it were, we may fly into a hypomanic or a manic episode, which in itself is not helpful. So I think that ultimate approach gives a much broader view of mood disorders, for example, and it helps in terms of describing the whole human experience of mood change in a much broader way. It highlights the fact that mood changes occur on a spectrum. It highlights the fact that people with mood disorders are not categorically different from people without mood disorders. That, we all have inherent moodostat systems that can go awry if we're sufficiently stressed or sleep deprived, or we take drugs or whatever it might be. We all have a potential risk for dipping into a depressive episode or potentially a hypomanic or a manic episode. So there's all types of implications from that in terms of psychoeducation for our patients and their families, in terms of destigmatizing people with mental health problems. There's less potential othering of people with mood disorders. Whereas I think that the traditional approach that I would have grown up with as a trainee was that, you had very specific clinical criteria and people were categorically defined as having a condition or not. And then there was a particular treatment that followed that. And I think, as I'm sure you'll agree, any clinician listening will agree, the longer you go on in clinical psychiatry and clinical medicine, the less categorical you become, or the less categorical I think categorically you should be anyway, because you realize that even for one particular condition like a depressive episode, two individuals may have a completely different set of symptoms that may not even overlap with each other. So while diagnosis and clinical criteria are important, they're really just a guide. And the evolutionary perspective takes us beyond that categorical approach and that proximate approach to broader questions of syndromes and spectrums and underlying systems. And that can only be helpful, I think, in terms of, as I say, psychoeducation, explanation for people, destigmatizing, and in terms of, opening up new questions for clinical research and educating future generations of doctors as well.
Yes, and I did always find it so unusual when I was training as a psychiatrist that we would jump straight to the pathology without trying to explain normal psychological phenomena. I remember when I was training in med school, before you learned about kidney disease, first you had to learn about the kidney. You had to read a whole book about the kidney and how it works in fine detail, just under normal circumstances. And then once you've done that, you kind of graduate to the point where you can start to learn about what actually goes wrong. And in psychiatry, we didn't have that. We didn't learn about emotions. Why do we have moods? Why do we feel happy some days, sad other days? Why do we have personalities? We didn't really look into personality in depth, and personality in particular is something that I really get a lot of value of taking an evolutionary approach towards, both when you're dealing with people and on the more severe end of things, but especially in my psychotherapy practice, because ultimately everyone has a personality, and who couldn't, use a better understanding of their personality in their personal life, their professional life. And certainly, yes, I agree, a dimensional approach, once you've practiced for long enough, really is the only approach that makes sense. And it's hard not to feel that the reason we use a categorical approach is simply because that's often, I think, kind of a shortcut, a heuristic of the human mind to put things into boxes, rather than because it actually represents sort of a underlying clinical reality. And I think, a lot of psychiatry is starting to catch up with this. So really, going back to the proximate versus ultimate, if you look at bipolar, as you mentioned, a proximate viewpoint says you have this disorder called bipolar, and it means you have manic episodes which look like this, or depressive episodes that look like that. And if you meet the criteria, then you have bipolar disorder, and you get some treatment to try and sort of quell that. And what you're saying is the ultimate approach. There's to ask, why do we have moods in the first place? Why do we have this mood system of ups and downs, and how does that go wrong, and what does it look like when it goes wrong?
Yeah, exactly. So I think ultimately it's humanizing, and it makes us, I think, as well, having that evolutionary perspective makes us more tolerant of the variation we see in everyone around us, our patients and everyone else as well. We're all different. If we were all constantly euthymic, it would be a very boring, probably unproductive world to live in.
Yeah, absolutely. Yeah. Tell me about evolutionary mismatch, and how can evolutionary mismatch affect our mental health?
Yeah, so I think this area is probably the most important area in terms of providing evolutionary explanations for mental health and normal mental health and mental illness. Just to go back to your point about studying the normal first, I think that's a very important point to emphasize as well, because in my early days reading about evolutionary psychiatry, it was a relatively new area back then, back in the late 90s. There's a lot more since in terms of publications and research, but back then it was new, whereas evolutionary psychology was a very well-established field. And I remember reading a number of evolutionary psychology books, which I thought were really good foundations for this whole area. David M. Buss, in particular, I remember his textbook was a kind of a core book for me for many years. So as you say, I think learning about the normal is essential before you start learning about levels of distress and mental illness and disorders. And that raises a question as to, and it's just something worth, I suppose, considering, is evolutionary psychiatry a branch of clinical psychiatry, or is it a branch of psychology? I mean, maybe it's not that important whether we decide on that, but I think you do have to have a very good grounding in normal psychology, and as you say, study personality and other such important core subjects in psychology before you can venture into looking at how these systems and these traits and these characteristics can go awry in mental illness. But just to come back to mismatch then, as I said, when you think about it in concrete terms, we as a species evolved and spent 98% of our time in small groups of hunter-gatherers, 50 to 150 people, rarely saw outsiders. Our circumstances were usually very, very, dangerous. There was predators, limited resources, no stable food supplies. There were some benefits, I suppose, in that, there weren't all these kind of made up jobs that we have to pretend to do these days. People maybe foraged and hunted in the morning and could relax in the afternoon and the evening. Who knows what it was like? And there is this concept of EEA, which is the environment of evolutionary adaptedness. But of course, that's a myth, because there were probably lots and lots of different environments of evolutionary adaptedness for different individuals, depending on the niche they found. But for 95% of our time during a very, very slow biological evolution, that was us. And then suddenly, 10,000 years ago, we started to develop farming and animal husbandry, and there's agriculture, and then there's production of grain and bread and beer and all the rest of it. And then it just goes on and on and on at a logarithmic scale, especially the last 2 centuries with the Industrial Revolution and other technological developments, and especially, again, even in my lifetime, in the last 50 years, life is unrecognizable in comparison to the life of my parents or grandparents. So, but meanwhile, our biology is essentially the same. So the way I kind of describe this to students, and it's an oversimplification, I know, but it's almost like we're a Stone Age species living in this futuristic world, where most of us don't really know how things work anymore. You don't know how your phone works or how your computer works. Well, I certainly don't, or my car or anything else. We just take it for granted. But if one of your ancestors from 500 years ago were to arrive, they would probably think most of these things operated by magic, and they'd be right to make that assumption. You'd be understandable that they'd make that assumption. And plus, so from a, not just from a technological point of view, but in terms of our environment generally, what we're exposed to now is we were exposed to novel environments, novel social networks. We have less contact with family. We have more contact with people we know nothing about. We have more superficial social contacts. We're exposed to novel synthetic drugs, to high potency alcohol that we haven't really evolved to manage at all. And so there's all types of comforts that go with modern life, but there's all types of novel threats and stressors as well. So one again, concrete example that we could talk about potentially is ADHD in children. Okay, so particularly in boys, as we know, it's a relatively common condition. Depending on the country you're in and the level of recognition and awareness, prevalence can be maybe 1% up to 10%. It depends, and it varies widely. And that in itself is source for something for discussion. We know it tends to be commoner in boys than girls, usually across cultures. And if you take the evolutionary perspective and the mismatch approach and look at ADHD, I think it helps to explain a lot of what's going on for kids with this condition. Again, going back to our environments of evolutionary adaptiveness, learning was very much as part of a group. There was intergenerational learning, and kids taught each other different things. There was learning by example and learning by action. Kids were freer to roam and wander, burn off energy, and to explore and to satisfy their curiosity. Whereas, the last 100 years, I'm not sure how long we've had the formal education system we have now, maybe 1 or 2 centuries, which is only a blink of an eye in our evolution. Kids are expected in Western educational systems anyway to sit in classrooms for 6-7 hours a day and to listen and comply. And for many kids, it's surprising how many kids actually can adapt to that, considering our evolutionary past. But a small number have difficulty. Now, it's not to say that every case of a child with a diagnosis of ADHD is because of evolutionary mismatch. Obviously, kids may have lots of other complex comorbidities, sensory difficulties and specific learning difficulties and so on. But I think the attention and hyperactivities aspects can, in many cases, be explained by mismatch, and taking that evolutionary approach and that mismatch approach can lead to novel and original ways to help these children, to help their families, and to help their educators. So, for example, introducing more physical exercise for kids, especially boys, may be helpful in terms of improving focus and concentration. More experiential, action-based learning as opposed to being constrained to sit at a desk can be helpful. And I know there isn't a huge amount of original research in the area as yet, but I know that anecdotally, talking to colleagues, say, in child psychiatry, these kinds of principles really, they can relate to them, and they will give you anecdotal examples of kids who have benefited from that approach. So I think that's a useful everyday example of a condition that is, I think, at times concerningly high in terms of its diagnosis rates, to a point where you wonder really what is going on. Is it really, if a condition is evident in 10% of children, is it a disorder at all, or is it a normal variation on a spectrum? And is there something that's wrong with the environment or the educational environment that we need to fix, as opposed to taking the other approach of diagnosing these children and potentially medicating high numbers of these kids as well? So that's one potential area of application for mismatch. There's loads of others, in terms of, as I say, exposure to novel synthetic drugs, high potency alcohol, and as I say, I think that the social network side of it is very important too. It's all potentially very novel and stressful, particularly modern urban living in big cities. It's completely alien to what we are evolved for, and it's surprising that we have adapted so well in such a short period of time. But it's not surprising that it would be stressful for many people.
Yes. And lingering on ADHD for a moment, because I think it's a really important topic. You've introduced the idea that perhaps part of what might be going on with ADHD, especially in children, is a mismatch between a child's disposition and the formal educational setting. And I think that's important. But also, what about an early in life environment now that is much more technological, with a lot more technologies that specifically provide short bursts of intense stimulation? One question I've wondered about with a ADHD expert in the US, Dr. Russell Ramsey, is, could it be that having an environment full of short, intense stimulation can condition a developing brain to remain hooked on and to respond mostly to short, intense bursts of stimulation, which is, it's not entirely what ADHD is, but it's a big part of what ADHD is?
Yeah, I mean, I don't know enough about the area to comment on that. I'm not sure if there's any research in the area that I can think of straight off, but it does make sense. It's an area worth exploring, certainly. Yeah, and the flip side of that is that immersing oneself in nature can to focus one's attention in a more natural way as well. Listening to bird song or smelling the roses, as it were, uh, can help to divert our attention in a slower, more natural sort of a way. So I would say that approach is much more sensible. But of course, there's practical limitations as well. We can't just come in and ensure that every child has 3 hours of exercise built into their school day, and that every child has, maybe someone there to guide them, and one-to-one approaches. That's expensive and difficult to deliver. But at the same time, I think we as scientists and as clinicians should be aspiring to the best possible approaches to help children. And to go back to your early comment about shortcuts, this is the proximate approach in terms of ADHD is to diagnose, treat with stimulant medications, put on some sort of a program, and it's a shortcut approach. There may be some benefits, but really I think you're missing the bigger picture for the child.
Yeah, absolutely. And there's a reason why ultimately, even when we're creating management plans for people with ADHD, aside from medication, usually a good clinician will also recommend looking at your nutrition, looking at your exercise, reducing your use of technology. So like the management is actually hinting that there's sort of more going on than just an absence of stimulant medications. And if I'm working with someone who has ADHD, I usually encourage them to build a foundation of managing symptoms without medication, and then potentially adding medication on top of it more as a bonus rather than as the mainstay of the recovery. Commenting on a point you also made, there's a limit to what we can do as clinicians, to ensure everyone has 3 hours of exercise a day and so on. That's true, but if we take this more evolutionary understanding seriously, it really has deeper philosophical implications about what a mental health condition could be, and it's really takes things. It could potentially, in some cases, take things out of the role of psychiatry and more in the role of culture, preventative medicine, education, government, and becomes more a responsibility more of our society as a whole, rather than psychiatrists who are really, we're kind of designed, we're doctors, so we're designed to, by definition, to deal with disease states, not to kind of manage the mental health of a whole culture in a preventative sense.
Yes, exactly. And again, that's very relevant to ADHD because, as you know, there's huge variations in terms of diagnosis rates, say between the US and say certain European countries. So there isn't there shouldn't be a biological difference. So why are there such differences in terms of diagnosis rates? And it may be due to societal expectations and different factors beyond the reach of medicine or psychiatry. But we should have a voice in terms of informing how these areas are optimized. It's interesting you mentioned as well that kind of that holistic approach, say, to managing a condition like ADHD, where we look at diet, exercise, and so on before we even get to medication. And it makes me think as well of the biopsychosocial model as we currently use it, and you and I have been trained in that, where we're encouraged to think broadly about diagnosis and treatment in terms of biological, psychological, and social aspects. And it's very commendable, and it's been around for a long time. But I think that without an evolutionary overarching framework, sometimes we can pay lip service to that kind of biopsychosocial model. It's almost like it's a tick box. And as you say, there's, philosophically, it's maybe a little bit empty unless you have an evolutionary framework to pull it all together. So I think biological, psychological, and social aspects of mental health problems and mental illness, first of all, aren't individual silos. They can all interact with each other, the biological, social, and psychological. And also, I think the biopsychosocial model doesn't take into account issues of phylogeny in terms of traits that develop in us as a species over our time as a species. It takes into account to a certain degree ontogeny in terms of our own personal development, but again, at a very superficial level. So I think, and this is something that Riyad Abed and Paul St. John Smith and Adam Hunt have written about in one of the chapters in Evolutionary Psychiatry, a multi-author textbook published in the last year or two. They talk about developing an Evo biopsychosocial approach. So, for example, when it comes to your ADHD advice, I think if you're selling that as a package or a treatment plan to someone, having an evolutionary framework, I think, could really help to bring it home. It makes sense to someone that this is why it is important that you get exercise, and this is why it's important that you look at your diet, and this is why it's important that you look at your daily structure and your time management, and how it's important. This is why your environment should be modified within reason. So again, it's as I said from the outset, I don't see evolutionary perspectives as replacing existing models necessarily, but I think they add an extra layer of meaning that should help to sell what we're trying to sell to people in terms of treatment plans and supports.
Yeah, and the truth is, patients can tell. Patients can tell if we're going through something as a tick box exercise versus if we actually believe it's important. Like, if your diabetologist, spends half an hour talking to you about insulin, and then also says, oh, and also you should pay attention to your diet, and that's the end of the consultation, unconsciously or very consciously, maybe the patient is picking up the fact that really the doctor thinks it's all about the insulin. And incidentally, I think diabetes and metabolic syndrome and obesity is an excellent example of mismatch. But leaving that aside, patients can tell what we think is the real advice and the real medicine and what we don't. And that's, sometimes when I'm trying to highlight these more holistic ways of managing a condition, I really go out of my way to say, this is important. This will, like, exercise will help your depression, for example, or your anxiety. So I think I think that there does need to be a culture shift in medicine, particularly in the way we're taught. We're taught in a system that emphasizes these proximate causes and therefore these proximate solutions. And I do think that ultimately needs to shift if we're going to produce doctors who are capable of seeing things in a less siloed and a more holistic manner. But I like the idea of having a biopsychosocial Evo approach, and I might add existential. So like biopsychosocial Evo existential, just because I think there's also, this is my personal affinity for more sort of existential questions, and with that in mind, let's move on to evolution doesn't care about our happiness. So can you give me an example of what that could help us to understand in the consultation room?
Okay, so if we take, for example, the anxiety, the example of say generalized anxiety or panic disorder, okay, we know that this can be, people with high levels of generalized anxiety and panic disorder can be very, very distressed by their symptoms, very disabled to a point where, they withdraw from society, lose out on opportunities, are in constant dread and fear, may need lots of reassurance that they're not physically unwell. So it can be a very, very serious condition. I think by definition, it is a very serious condition at a case level. And an evolutionary perspective can help. If I'd use a specific example again used by Randolph Nessy, which is the smoke detector principle, and the idea here is that anxiety and panic are a type of natural alert danger awareness system that we all have, and that in our primitive past, being on high alert and being vigilant for threats and predators was very important. Um, um, Nowadays, there may be different threats depending on the part of the world you're in. Where we live, thankfully, existential threats are not that prevalent, but still, for many of us, we live in high states of anxiety, and we may have panic disorder and panic attacks. And the smoke detector principle essentially makes the point that in someone with anxiety and panic disorder, their natural threat detection system is on high alert, even in the absence of an obvious threat. So, and while that may be very distressing and disabling now, it may have been helpful way back in our evolutionary past. So to use a smoke detector analogy, having a smoke detector in your kitchen that goes off every time you make toast is annoying and distressing, but at the same time, if it goes off the one time in 100 when there is actual fire, it will save your life. So the same with anxiety and panic. The false alarms are distressing and disabling, but on the other end of the spectrum, if you were hypo-anxious and you had zero levels of anxiety, or you weren't vigilant enough, you'd be picked off by a predator. So that's a sort of approach that in anxiety and panic now, it's not necessarily that there may be some obvious underlying psychological reason for your anxiety or panic. It may simply be that your threat detection system is oversensitive. And then the implications of that are, first of all, that medications such as SSRIs are helpful. It doesn't rule those medications out, because we know that in taking those medications, they reduce the acuity and the frequency of anxiety and panic symptoms. So you can stand back and maybe observe the symptoms more than actually feeding them. So that's one benefit. And from a cognitive point of view, it can be helpful for patients to tell themselves that the next time they have a panic attack, that instead of catastrophizing and feeling there is some existential threat, or that they're having a heart attack, or that they're going to die, or that there's some underlying psychological reason for it, there may or may not necessarily be. It may just be, and I know I'm being deliberately overly simplistic and concrete here, but it may simply be that their threat detection system is too finely tuned. Okay, and that cognitive trick, as it were, can be very helpful. And again, I'm quoting Leslie a lot, Randolph Leslie, but he would say that in his anxiety disorders clinic in the US, when he gave that explanation to people, I think about a quarter of people didn't need to see him again, because they could put that into action, and it helped. Now, in conjunction with medication and with CBT as well, but that particular explanation was powerful for many people. So it's at the moment we are doing some research in Ireland and the UK on this, where the data is being collected right now, but we're looking at clinicians, junior doctors and consultant psychiatrists, and asking them questions about the smoke detector principle and how that might be of value to them in treating people with this condition in everyday practice. So to come back in a long-winded way to your initial question, the evolutionary perspective indicates that even with high levels of symptoms and distress, while disabling and distressing, may be one of the reasons why you're still around, because your highly anxious and panic disorders ancestors were, as a result, vigilant enough to avoid being picked off by predators, whereas your hypo-anxious ancestors didn't get to survive and reproduce. So it's this inherent threat detection system that we have all inherited. And for some of us, maybe through a combination of early life experiences, or any number of other issues, too much caffeine or whatever it might be, we we set that system too high, it's too finely tuned, and it causes us distress. So I know it might sound simplistic, but it's a cognitive approach, I think, which can complement CBT. You know, CBT is obviously very helpful, and there's a good evidence base, and there's a good rationale for it. But I think adding that extra little bit of evolutionary perspective, I think, could really sell the whole area to people and make CBT principles more persuasive and more helpful for them.
Yeah, I think that's a really powerful example, and it's so, I'm sure, I think it is therapeutic for people to realize that we're animals, we're biological organisms, and we have instincts. And having an instinct doesn't mean that there's something wrong with you. It just means that this is some software that evolution programmed into you, and it's a normal instinct to have, even if it's not entirely appropriate to the situation. I'm sure that does provide a lot of relief to a lot of people. And an example, maybe a bit of a softer example I'd like to add in highlighting this principle, is what Freud would have called garden variety unhappiness. You know, Freud often felt that if people were treated well in psychoanalysis, if they got over a lot of their neuroses, it didn't mean that they were like super happy and euphoric. They would just be garden variety unhappy like most of us. And there's a value to a low level of discontentment and unhappiness, because it means you're pushing for more in your life. It means you're going to be looking for new opportunities. Maybe you're going to try and get better in some way. And again, evolution really just cares about our reproduction. So as long as you're in a position to reproduce, there's no reason really for the bliss that we're so often seeking. And so the bliss almost becomes like a mirage in the distance to keep us in motion. And I think if there's one enormous problem I have with modern society on a cultural level, is that the myth that you can achieve bliss, that you can achieve a kind of euphoric, hedonistic, permanent state of like happiness is stronger than ever. The idea that you can get to a point, whether it's by having six-pack abs or a million Instagram followers or success in your career or a lot of money in the bank, whatever route to get there, that you can get to this state of no longer feeling unhappy, of no longer feeling anxious, of no longer feeling a certain sense of wretchedness or angst. I think that myth is stronger than ever, and it's that bar is too high for anyone. And if you're adding to that not doing so well in life, it's even more crushing. We've lost this sense that life is actually supposed to be hard. Of course, life is hard, whether we think it's supposed to be or not. But we also think it's supposed to be, and that makes it even worse.
Yes, exactly. Yeah. I can't remember the exact quote, but it brings to mind Charles Kingsley he was a philosopher, theologian from the 19th century, and he spoke about, the purpose of our existence is not necessarily the pursuit of comfort and happiness, but it's to find something to be enthusiastic about. And as you say, what drives us to be enthusiastic sometimes is a sense of unhappiness with our current situation, and that motivates us to improve. But and there is some, as you say, some mirage of eternal bliss out there, but none of us would ever reach it, because if we did, we'd be in a constant static sort of a state. We'd never do anything. So
and often even the people who seem to have attained it seem the most dysfunctional and unhappy. And you think of like situations like the Johnny Depp Amber Heard situation, where for so long so many people would have been wanting to trade places with them. Some people might still want to, but I remember there was a documentary I watched about their whole trial on Netflix, and there was just like one video in Johnny Depp's kitchen, and they're like arguing, and it's extremely dysfunctional. And you think, who knew from the outside, watching them on the news or watching all their success, that being in Johnny Depp's kitchen can be so terrible, can be like almost a hell on earth, psychologically speaking. It's just, we don't know, the mirage is too strong.
Yeah. Maybe on a more lateral point, one of the things that the evolution perspectives makes me think about as well is the role of and this may be, you obviously know more about this area than I do in terms of Jungian analysis, but the role of the doctor as a healer, and the doctor as a kind of a primitive, it's not a primitive archetype, but as a primitive individual, a symbolic individual in the community. And for me, and this sounds a little bit out there, but the evolution perspective for me reminds me how important it is to, even if you don't have immediate answers or an immediate solution for someone, to at least behave in a healing way and to empathize and to make a human connection. And that's consistent with, principles, psychotherapeutic principles of creating a safe space. And as you said earlier on, allowing someone to reflect back to you and allowing for a sense of Conor Garden unhappiness and so on. But being there as a reliable sort of anchor for someone in a kind of a healing role. I think maybe that's something that we miss in modern societies. I know I'm kind of going a little bit off topic now, but in a kind of a post-religious world where there aren't priests or preachers to relate to, having a healer or someone we can talk to is very important. Whether that's a doctor, a psychiatrist, a therapist, a counsellor, whatever it might be. But I think we all yearn for that individual at different times in our lives. So I think I find in a busy clinic where you've seen someone, you've prescribed all the usual medications, they're doing their psychotherapy, you're aware of all their background and their upbringing and their family network, just putting yourself there as a healer for them and connecting with them at a human level can be very powerful. And just doing that consistently for them can give them an anchoring sort of sense. And again, I think, I know this is all speculation, but you could speculate that maybe in our evolutionary past, in these groups of 50 or 150 people, there were one or two individuals who people went to when they were stressed or when they had lost something or when they were feeling threatened, whether that was an elder or someone who was just good at that sort of thing. So I think this is more speculative now, I know, but I think it helps me to, as a doctor, as a psychiatrist, the evolution perspective helps me think more broadly, but it also helps me think about myself as part of the broader social network of my patient, not just as a clinician diagnosing and treating them.
No, I think there's a lot of validity to that, and that makes me think of the work of a psychoanalyst named Bion, who talked about a lot of things, but one thing he talked about was emotional containment and how people feed back emotions to each other. So, for example, when a child is distressed and they may be experiencing very strong emotions, perhaps for the first time, they don't have the words to capture them or to contain them. And so that contributes to the emotion feeling very overwhelming and kind of unbearable. And what a parent will often do with a child is to figure out what emotion the child is experiencing and give them words to describe it. And words don't just help us describe emotions, but they help us to contain and understand them. So whatever unbearable feeling a child might be feeling, if they now know, okay, this is anger, this is temporary, this has a specific cause, this has a specific solution, all of a sudden there's a level at which that the child's able to contain that emotion and manage. And I think similarly, as doctors, we do that all the time. So often as a doctor, I felt, especially before psychiatry, I often felt my main role was to inject a sense of calm to the situation, even if I didn't necessarily add something new, although often you would add a practical solution. Often you're just providing a sense of context, calm, we've seen this before, this is the kind of thing we might do in this situation. Definitely true in psychiatry and psychotherapy as well. So I think that's definitely an important point. We have this pastoral role sometimes that's been lost. But we've talked about a lot of conditions so far. We've talked about bipolar disorder, ADHD, anxiety. One last condition I'd like to cover is, because it's under discussed, is psychosis and schizophrenia. And for those who don't know, the basics of psychosis are, if someone's having a psychotic episode, they might have auditory hallucinations, so they might hear things, they might hear voices, they might have visual hallucinations, although less commonly. They might be paranoid, they might have frank delusions. So if you're psychotic, you might, for example, believe an organization is out to harm you in some way. This is the kind of thing that can happen. How can evolution help us to understand something like psychosis or schizophrenia?
Yes. So I think it's probably just as well we left this one to the end in terms of the clinical kind of conditions, because it's among the most complex and debilitating and most difficult to make sense of from an evolutionary perspective. And there are multiple theories, at least 8 or 9 reasonably good theories at my last count. But the one that appeals to me most is the whole area of cliff edge fitness. Okay, and again, this is going back to Randolph Nessie's approach, his theory. So if we look at, going back to normal psychology, normal human cognition, social cognition, normal human capacities like social cognition, theory of mind, language, we have these what can only be described as kind of superpowers when you think about it. We can look at someone, we can look back, we can infer what people might be thinking, we can convey really, really complicated ideas through our vocal cords. It can be picked up by the other person, interpreted and fed back to us. It's almost like magic when you think about it. No other species comes even close to what we can do in terms of communicating with each other and picking up on each other's language, but also nonverbal cues. And for 99% of us, we can do this perfectly well and manage every day with the technical aspects and the interpersonal aspects of our life. But the cliff edge approach to psychosis suggests that because our mind reading, theory of mind, and language abilities are so highly developed, that the analogy is used with that of a racehorse and the length of a racehorse's legs. Okay, we breed racehorses to have long legs so they run faster, but there's a cost to that, and that they have long, skinny legs that can get broken at times. So likewise, with social cognition and language, we have highly developed social cognition and language skills, but in a small number of people in every generation, unfortunately, those capacities go over a cliff edge, and people can develop problems in those areas. So as we know, with schizophrenia, there can be inherent difficulties with semantics and the understanding of words and the production of words and language. And there can also be difficulties with social cognition and interpreting people and interpreting people's nonverbal cues and their motivations. So as you say, people can become frankly delusional, where they look at another individual or they look at a group of people in the room and they infer some a harmful causality behind it, think people are against them or out to harm them in some way. So that's I think the most appealing approach to me, and I think it explains a lot. It explains the fact that schizophrenia does crop up in every generation. The rates vary, why I think we have this kind of a truism of 1% in every generation, but if you look at that across different cultures, there's actually a huge amount of variation in that, between maybe 0.1 and 1%, which is a lot of variation. But it tends to be more common, as you know, in urban settings and maybe second generation migrants, and then that combined with early adversity and early drug use and so on, all have an effect. But I think that approach is helpful because it humanizes the individual with psychosis and schizophrenia. It again highlights how the fact that we are not categorically different. It may be just that the same underlying traits and systems for that individual have just gone somewhat awry, and as a result, they have problems. And it takes us away from categorically defining people as being schizophrenic and not, or having a psychotic illness or not. Again, as we all know, going back to the mood disorder example, if we're sufficiently stressed with sleep deprivation or drug use or whatever it might be, we can all tip into, low grade levels of paranoia and suspicion. And, even from a medical point of view, the condition of delirium is a psychotic state that's precipitated by medical illness. So that you could argue that there is psychosis, and psychotic thinking is a kind of a default state for some individuals when they're unwell. But again, just to summarize, I suppose it brings us back to a discussion about underlying systems and normal systems and traits, as opposed to getting focused on the endpoint and the proximate approach, which is looking at whatever it might be, dopaminergic systems and anti-dopaminergic drugs, which again, obviously are helpful and very important in treatment.
So with psychosis and schizophrenia and paranoia, you're suggesting that there's a natural human ability we all have on some level to kind of infer something from something else, to draw a pattern. Someone smiles at me, maybe one person might interpret the smile as a sign of affection. Another person might interpret the smile as perhaps this person is out to get me in some way. And it reminds me a bit of the smoke detector principle with anxiety and panic, in that, if you are disposed to be a bit more on the paranoid side of things, it might be bad for you socially, but it could save your life the 1 out of 100 times that you happen to be right. So are you suggesting that it's this sort of this tendency to draw patterns that aren't obvious, that might go a little bit out of control and go awry?
Yes, I think so. Yes. And there's obviously, lots of other factors that may come in. So there may be a certain degree of genetic risk, early life adversity. There is the whole sort of traumagenic model for psychosis, which I think is very, very worthy of consideration. Early potent drug use, all of these things may combine. But I think the key point for me from an evolutionary perspective is that the systems it's acting on are normal systems that are stressed or that go awry for whatever other reason may be causing stress for the individual.
Have you received any pushback or criticism from colleagues or anyone else about taking the evolutionary approach to psychiatry?
I haven't actually. No, I mean, I think we have a special interest group in Ireland. We have probably about 100 members, and they're all very enthusiastic and interested in developing the field. I know in the UK there is maybe 15 or 1600 members in their special interest group. Whenever I talk to people about it, I suppose I'm generally talking to other psychiatrists who are by nature, scientific and intellectually curious and open to the idea. So I don't get any major pushback. I mean, I think psychiatrists do ask me, well, what are the clinical implications? How can I use these evolutionary perspectives to help me in my clinical practice? And oftentimes there aren't direct clinical applications. See, the smoke detector principle may be one, the moodostat analogy for mood disorders may be another. But instead of having a direct clinical implications, my answer to people with those questions are that really it broadens your whole perspective, energizes you, helps you to think more broadly about humanity and normal mental health and normal human experience and mental illness. And as a result, I think your enthusiasm can rub off on people. You can have more therapeutic and energizing encounters with people, and you may be able to pull together treatment plans that are more persuasive for individuals. So, so the lack of clinical applications is one. A potential criticism, which I haven't come across in practice, but I think is worth bringing up, is the potential for relying on just those stories. So, you can fall into if you're not careful, I think you can fall into giving kind of semi-plausible evolutionary explanations for different things that are not necessarily testable or researchable. And we have to admit there is limited research in the area of evolutionary psychiatry, and we need to do more in that area. And then I suppose the final potential criticism or pushback would be in terms of deliberate misuse of evolutionary principles, which would be very concerning. So, for example, using half-baked evolutionary principles to explain bad behavior or antisocial behavior. This is based on, people might trivialize such behaviors and say, well, this is because we were all hardwired and evolved to behave as warriors in our earlier development, and if it comes out every now and again in modern society, it's not my fault, it's my warrior genes. So there's that potential for misuse as well. But generally speaking, people are interested, and there's a broad group of people in Ireland now, psychiatrists, GPs, nurses, other healthcare professionals who have a general interest. In terms of direct clinical applications, I think that'd be one big criticism that people have, because there aren't immediate clinical applications. Yeah, for me, I know it opens up my mind in terms of thinking about psychiatry and mental health, mental illness, even in terms of engaging with people in other disciplines, and say psychology, sociology. I have a friend who's a marine biologist, and I think because of our shared interest in evolution, we can have very interesting conversations. They mightn't have direct clinical implications for patients, but at the same time, it opens up your mind. As you said earlier, we have we have a particular type of training in psychiatry in Ireland, in the UK, and in Malta as well, where you have to learn symptoms and diagnostic systems and treatment approaches, which is fine in terms of the core principles. But you would hope that as doctors, we would have more to offer than just being technicians that offer, an algorithmic approach to mental illness, and that we have a much more nuanced and a broader perspective on the human condition. As you say, philosophical and existential perspectives that should hopefully be helpful as well for people.
Yeah, and I think they are, and I think there is a sense, if you're training in mental health, whether as a psychiatrist, therapist, nurse, counselor, there's a sense that perhaps a lot of things within mental health are taken on too superficial a level, too shallow a level. That's how I felt when I started training in psychiatry, and adding these perspectives can be incredibly helpful, I think. Thank you so much for spending some time with me. Where can people find out more if they're interested to learn more?
So we have the College of Psychiatrists of Ireland Evolution and Psychiatry Special Interest Group. Okay, it's a bit of a mouthful, but College of Psychiatrists of Ireland Evolution and Psychiatry Special Interest Group. We have a web page there with lots of links. We have a YouTube playlist on the College of Psychiatrists of Ireland YouTube channel, where you can access all of our previous talks going back over the last 3 years. I'd also refer people to the Royal College of Psychiatrists Evolutionary Psychiatry Special Interest Group, SIG, web page, and they have lots of links there as well. We have a Substack. Gurja Brar has laid out on a Substack Evolution and Psychiatry, and that's well worth looking at. Randolph Nessie's webpage, I think it's randolphnessy.org, has a huge number of resources in terms of his background research and writing. So that's probably enough to get started on. In the Substack, what we're doing is publishing every 2 weeks different interviews with different people and updates and reviews of developments in evolution and psychiatry. And we're also every couple of publications, we're publishing chapters from an evolution and psychiatry clinical textbook that I published a couple of years ago, and this is a second edition of it. And we're hopeful that we can get a publisher, and that book can help clinicians to think about the evolutionary perspective in relation to everyday clinical conditions that they meet in the clinic, like, as we've discussed, ADHD, psychosis, mood disorders. It doesn't pretend to offer immediate evolutionary solutions for all of these conditions, but it can help, I think, just to broaden people's perspective and hopefully for the next generation, it can inform future medical education as well, so that people can get beyond the kind of currently constrained approaches to medical education and think more broadly. I mean, it's one of the things I find when I talk to medical students about evolution. They have zero experience of evolution in their degree. Some of them may have come across it maybe in an undergrad or in biology in high school or secondary school, but there's no teaching of evolution in medical school. So I think that's an area that needs to be developed. And I think another area we haven't touched on, but it's something to consider, is the whole area of genetics. I think advances in genetics in the last decade have been, amazing, but at the same time, I think without an evolutionary perspective, psychiatric genetics is very limited. There's still this approach where you're almost looking for an oh God answer, one gene, one disorder, or a number of genes that confirm or that are associated with a particular disorder. But the evolutionary perspective indicates that we should be looking at genetic risk broadly in terms of systems as opposed to particular disorders as well. So I think that the evolutionary perspective will help in how we interpret genetic findings as well in the longer term.
I think that's an excellent point and potentially a topic for a future podcast. I mean, for people who are interested, we also have had Dr. Andy Nesse on the podcast about a year ago, I think last September, so you can check that out. And we've had Professor Catherine Lewis, a geneticist, talking all about genetics, including sort of the multi-gene approach. So check those out, and I'll put some links to the resources you mentioned in the description. But thank you so much for your time today and for coming to chat to us.
Thank you, Alex. It's been a pleasure. Good luck with the podcast.